Well, good evening and welcome to any and all of the people who are joining us this evening for this webinar. Thank you so much to Sexual Medicine Society for this opportunity. I think it's a great chance to talk about some really important things this evening. And so we're going to get started in just a minute. We're going to be talking about Peyronie's emotional distress, helping men cope with Peyronie's disease. We're going to really focus our goal is to get to the psychological implications and distress eventually, and that's what we're going to focus most of our energy on. But I'll start by going through some information, some basic information about Peyronie's disease, so that we kind of have a grounds to work from, and then we'll segue into really talking about some of the true psychological distress that can happen for many of our patients and many of these men that we see with Peyronie's disease. I'm guessing a lot of you out there see men with Peyronie's disease just like I do every week. And so some of this information may be, especially in the beginning, a little repetitive for you, but we want to make sure that everybody understands and that we've talked about and covered it as completely as possible. So I'm really excited because this evening, Dr. Christian Jordell is joining me. He is the chair of the Department of Counseling and Family Therapy, and he's an associate clinical professor at Drexel University. He's the former editor of the Journal of Family Psychotherapy, the Journal of International Family Therapy Association. He has formerly held board positions for COAMFTE, as well as the North American Accreditation Body of Marriage and Family Therapy Education, as well as the Commonwealth of Pennsylvania Board of Social Workers, Marriage and Family Therapists, and Professional Counselors. He is a licensed marriage and family therapist with 16 years of clinical experience. He also is an ASEX certified sex therapist supervisor who works extensively with individuals, couples, and people in relationships. He has a private practice in Philly. So most of you, well, some of you probably know me, maybe not, but I've been around Sexual Medicine Society for several decades, and so my name is Dr. Jeffrey Albaugh. I'm a board-certified advanced practice urology clinical nurse specialist, and I also am certified by ASEC as a sexuality counselor. I split my time in the private sector at North Shore University Health System in Chicago, and I also work at the Jesse Brown VA Medical Center, where I do couple therapy as well as some of the other things I do with my patients there. I run a sexual dysfunction clinic in both places for men and women with sexual dysfunction, seeing a lot of patients like you guys all probably see in your practices as well. And so we're going to start our presentation without further ado. I'm going to pull that up right now. And okay, so let me go backwards just a bit to the beginning. Maybe not. Let's see. Hold on. Let me stop sharing and go back out. That's not working right. Hold on just a sec. Let's try this way. Okay. All right, now it will let me go. It's supposed to start at the beginning, but there it goes. Now we got it. Okay, we're ready to roll. So you know who we are, and we're going to be providing this information for you this evening. So we're going to start out by just talking a little bit about Peyronie's disease. Sometimes you'll hear us refer to it as PD, just for sake of moving along quickly. But Peyronie's disease is a progressive condition resulting in fibrous plaque formation within the tunica albuginica of the penis. And so this specific disease was named after Francois Peyronie. He was a surgeon to King Louis XIV, who in 1743, Francois Peyronie described rosary beads of scar tissue extending the full length of the dorsal penis. So this can lead to, in some cases, as you all know from your practice, Peyronie's disease can lead to penile deformity, such as shortening, narrowing, curvature. A lot of people equate curvature of the penis with Peyronie's disease, but that's not always what happens. Sometimes there can be more of an hourglass syndrome or other or shortening as well. Some people may have pain, especially initially after the if there was any trauma. They may have pain, sometimes bruising, swelling, things like that, but it can also cause psychological distress. We're going to get into a little bit about Peyronie's disease. It is a plaque that represents fibrosis that forms within the tunica albuginica, typically commencing at the convergence of the septal fibers with the inner layer of the tunica, dorsally or ventrally. So most of the time in my practice, what I find when I'm checking patients is it's like a band of hard tissue, a fibrotic band that goes across the paired corpora on the top. That's probably the most common finding I find when I find it. But you may find it on the bottom side. You may find it on the sides too. But a lot of times it's like a band of hard fibrosis tissue that goes across the paired corpora, but I've seen it all different ways, but that's probably the most common way that I've seen it. It can be fairly thick in length along the shaft. It can be thinner. And a lot of times I find it will go right across the two paired corpora. Not always, but oftentimes. And the plaques can occur wherever. The plaque is composed of altered and disorganized collagen combined with a reduction in the density of elastin fibers. I want to talk a little bit more about the pathophysiology. It is an acquired localized fibrotic disorder of the tunica albuginea. So it's a localized aberration of a wound healing process. Some of the theories are that there's bleeding within the tunica albuginica, trapping fibrin and inflammatory cells, and this causes an overexpression of matrix proteins secondary to an upregulation of cytokines and growth factors in the local environment, leading to plaque formation. Also, they believe that excess fibrin deposition in response to microvascular injury, so trauma, an upregulation of transforming growth factor 1, TGF-1, results in plaque formation. So these are some of the things. You can see that the cause is unknown. There are a couple different risk factors, though. So when you're looking at your patients and you're getting your history, you're going to want to evaluate them for, of course, a family history of Peyronie's disease, but also, do they have Dupuytren's contractures? That's a risk factor. Genital or perineal injury or trauma it may have occurred, and you're asking about that. After radical prostatectomy, we find that patients will complain of this issue more often. So if they've had a radical prostatectomy, that's another one that they consider as a risk factor. If they have planners, fascial contractures, or tympanosclerosis, so different things where you see fibrotic scarring in tissue in other places may make you think this could be linked to Peyronie's disease. If they've had urethral instrumentation, if they have Paget's disease, gout, or lipomas. Those are some of the risk factors. So this trauma leads to inflammation and scar tissue. And like I said, we don't know exactly the cause, but those are some of the risk factors. And this is from the AUA core curriculum. So how prevalent is it? Why do we even need to talk about it? Well, you can see, I'm going to show you a couple different studies, and this one here shows you that definitive, I mean, they've had a formal diagnosis of Peyronie's disease was about 0.7%, but probable patients complaining of the things that we just talked about was about 11%. You can also see prevalence by years and age that I listed there for you. Some of the chief complaints of the people who had probable Peyronie's disease were that they had a new significant curve or bend. This is a lot of times what we hear from patients who have Peyronie's disease as a primary complaint, and about a third of them had that. A lump, a bump, or firmness, hardness affecting the shape of their penis, but even more common, a lump or bump under the skin of the non-erect penis. That was about a quarter of them. Unusual firmness or hardness tissue under the non-erect penis, almost half of them. Erect penis folds during intercourse, it buckles or folds, and a noticeable narrowing of the erect penis. So some of the things they complained about. And so when we think about, and this is another study, this was a German, a validated questionnaire in Germany. They had about a 55% response rate. And again, here you see about 3.2% of the men in that study reported Peyronie's disease. And you can see again the age breakdowns. The complaints weren't too dissimilar: curvature or angulation, painful erections, erectile dysfunction, and a combination of the above. So of different things. So you can kind of see a little bit from each study. So if we look at the epidemiology and figure out, because we have rates from 0.5 to 20% of adult men, but the average is about 4%, which coincides with that other study that was around the 3% range. And so that's why we're seeing some of these men in our practice. It is something that men are struggling with. So how do they present to us in our practice? Well, first of all, certainly not all of them, but they can have a palpable plaque. When we think about their clinical presentation, to some of them, will this resolve? That's another thing a lot of people think, well, maybe it'll just resolve on its own. But when we think about this, about 10 to 12% in the research will resolve. That's not a lot of men. That's about 1 out of 10. About 40 to 67% will stabilize according to the research. So they'll become stable and not worsen after they stabilize. But about 33 to 48% will progress and get worse over time. 30 to 40% may have erectile dysfunction. So about a third of them will complain of that. Greater than 50%, and this is important, are distressed or depressed about it. So that's one study, and I'll give you some more studies about some of the psychological ramifications. So when we think about this stuff, these guys are showing up with, some of them have a palpable plaque, some do not. Some have curvature or bending of the penis, indentation or narrowing. I've seen it on one side or both sides, more of an hourglass effect. Shortening of the penis is another complaint I'll hear quite often. Pain, bruising, swelling, especially if they had a traumatic event. And certainly all patients, a lot of my patients don't recall a specific traumatic event, but some of them do. But a lot of them are like, I don't remember any specific event where I had trauma, bruising, pain, and all that. Some of the patients will, some won't. A loss of elasticity, and when we do our stretched length of the flaccid penis, that is compromised as well. We talked about erectile dysfunction, and of course our focus that we're headed towards soon is psychological distress. So let's just talk a little bit about how we evaluate them in the focused genital exam that we do. The whole process is engaging them in a process that will help us document the signs and symptoms of their Peyronie's disease. We take a very careful history and we do a focused genital exam. The history is going to include, tell me about when did it happen? How long ago did it occur? Has it worsened over time, or is it stable? Was there any triggering event? Most often the triggering event will be something like during sex. A lot of times the female may be on top, or the partner be on top, or they're in a position with the partner on top where when they come down wrong on it, it bends, but it can be anything and everything. But a triggering event where they had trauma doesn't always happen with Peyronie's, but sometimes they can identify that. Afterwards, what happened? Did they have bruising, swelling? Did they have pain? And do they have any deformity of the penis? Are they able to have erections still, or are they struggling with erection hardness using the erection hardness scale? And do they have any other symptoms? Also very important, can they have sex? If you didn't have a curvature, take the curvature out of it. Is your penis hard enough that you would be able to have sex? If you can't have sex because of the curvature. If they can still have sex with the curvature, then is it hard enough to have sex? But if they're unable to because the curvature is so severe, then if we take the curvature away, do you believe your penis is hard enough for sex? We also have a wonderful PD questionnaire that is a validated questionnaire. There's 6 questions, including distress, and the range of points is from 0 to 16 points total. With your physical exam, you're going to take a ruler and push it into the fat pad above the penis and explain to them that you're checking for the elasticity or stretchiness of the penis, and you're going to check that regularly to see what's going on there. It would be wonderful to have a pre-Peyronie's complaint stretched penile length to know even more, but most of the time you may not have that because they didn't have a problem beforehand, but you can check that. You're going to check the plaque. You're going to check the size, the firmness, the location, and any pain with the palpation of that plaque. If if you're considering treatment, especially surgery, you may want to do a penile color Doppler so you could document that plaque specifically and erectile function, so you can have all that documented before you take them, especially into surgery. That can be very important. So you have a baseline. So if they're complaining things are better or worse, you can say, hey, here's where you were before surgery. Here's where you are after with your stretch penile length, with your with your erectile function and things like that. So you want to use your validated questionnaires, both your PD questionnaire and your shim, or your full the full shim, or the abbreviated version of the IEF, which is the shim, or the complete IEF as well, which is the International Index for Erectile Function. So that's kind of some of the workup that we typically do. And then so what do we do for treatment? And I just want to quickly talk just a little bit about this, and then I want to move into what we really want to talk about this evening. With pain, you can treat that with NSAIDs. If they're able to have sex and the curve is less than 30 degrees and they're able to have successful intercourse and it's stable, then typically we do watchful waiting, because we don't want to cause any more scarring with doing any kind of treatments. And if they're able to have sex and it's 30 degrees or less, then watchful waiting is the typical course of treatment. And we do quite a bit of that with our patients in my clinic that fall into that category. Then we have interlesional injectables, and the FDA approved one is your collagenase. And so you can use that along with modeling, and the criteria says that they have to have a palpable plaque, because we have to have something to shoot this medicine in to break up the collagen. The collagenase has to be shot into that plaque. So we have to have a palpable plaque so we know exactly where we're going to inject that. And then they should be at least 30 degrees or greater and less than 90 degrees with intact erectile function. The other two interlesional injectables, interferon and verapamil, are also recommended with strength C evidence base. The FDA approved one is the first one, and those are the other two. Clinicians should also assess the patient as a candidate for surgical reconstruction based on the stability of their disease as well. All of this is from the AUA guidelines. The clinicians may offer, and so when we talk about surgery, we have plication surgery, we have plaque incision and excision, we have penile prosthesis. Sometimes they will just tighten up the other side of the penis to straighten out the curve. Sometimes they'll actually do incision and excision of those plaques, but there's lots of different things that can be done and have been done for decades surgically to correct this situation under the right circumstances. So a little bit about treatment just to cover that, and then we're gonna keep moving along. So here's one more thing, and then I'll come back to this. Here's some treatments that aren't recommended. We know for years we've tried some oral therapies with things like vitamin E, different things, omega-3 fatty acids, vitamin E plus L-carnitine. And so there is some evidence out there, but in general, these don't really show value as ongoing treatments from the research that's been done so far. In addition, you can see electromotive verapamil and ESWT, which is your electrocorporal shockwave therapy to treat Peyronie's disease, is not recommended. These are the AUA guidelines, except for pain management only. To segue into our psychological impact, I wanted to just pull up a couple studies to remind us of how important this is for our patients. When we think about psychological distress, 77% of the men in this study, this was back in 1990, reported negative psychological effects from Peyronie's disease. So then we look later in 2008, and we see 26% of men reporting moderate depression and 21% reporting severe depression, which means we have almost half the men in that study reporting some form of depression, either moderate to severe. And that doesn't even include the men with mild depression they believe is related to it. Emotional problems and distress, when we look at that, here's a larger study. Both of those studies contained about 90 some odd men. But here's a larger study that showed 81% reported emotional problems as a result of their Peyronie's disease. So this tells us these men are struggling. Their partners may also be struggling. When we bring our patients in, I try to encourage all patients to bring their partner in the clinic with them to be there for part or all of the appointment. And I think that's really important. And we need to be assessing and asking about distress, depression. How are they feeling about things and how are they navigating their way through? But I'm not going to talk any more about that because I'm going to leave that to our expert therapist. But let me double check real quick before I move into it if I have any questions in the chat about this first section, just going through. Let's see. Okay. All right, cool. I don't see anything. So I think we're ready to go into what we're really here to talk about, which is to talk about how we can help men cope with the distress caused by Peyronie's disease. And thank you so much for joining us this evening, Dr. Jordell. We're so thrilled to have your expertise. I'm going to forward to your slides and let you begin.
Thank you so much, Dr. Alba. Hello, everybody. Nice to be here. It's interesting. I always feel like that when I at sort of have the opportunity to participate in these type of events, I'm continuing to learn, notably as a non-medical provider. I'm going to talk to you tonight. I'm using a case example. This is a client that I've had. They're a premarital couple in their 30s, and so they are sort of at the younger end of some of the data that Dr. Alba had put out there around sort of the prevalence. I've been seeing them for probably about 6 months. They've been together for about 3 years and they're cohabiting. They presented to me. Now, what's interesting is that, I certainly work with a lot of clients who may present who are having sexual issues, but it's not as clearly defined what that is prior to sort of assessment. This was a particular case where the client came in with the Peyronie's diagnosis. And so he was under the care of a urologist. And specifically, that was a recent diagnosis. And so this was sort of a presenting sex therapy case that also had relational implications, because one of the things that's going on and has been going on for this couple, as we'll see, is that there was a great deal of anxiety for both of them. It was manifesting in different behavioral, sort of coping strategies, and it was leading to a lot of conflict. So if we could move to the next slide, please. And so, as part of any mental health practitioner who's trained to work with clients around issues like this, I did a pretty comprehensive sexual history, both of them individually as well as a couple. I think that what's interesting about this case is that, Ken, there was no, to your point, Dr. Alba, there was no sort of disclosed history of sort of trauma of any sort. And specifically, they, as part of the assessment as well, I'm looking at the onset, the development of symptoms over time. That was not applicable in this case, but certainly with other cases, I may have a client who is coming in where the disease is more progressive. I think the principal symptoms that were coming up, but certainly whenever I'm wanting to assess with this type of presentation and this type of diagnosis, is physical pain, to your point. What is the degree of physical pain? What is the degree of potential curvature? What is the history? Certainly a release of information to talk to the urologist, finding out the history of treatment. Not just what the treatment recommendations have been, but also treatment compliance. I think that one of the things that I've learned in my work over time with clients around Peyronie's is that, to your point, Dr. Alba, the majority of clients, this is a progressive disease. And so therefore, there is a bit, for lack of a better word, of an emotional kind of trauma to the diagnosis. There needs to be an adjustment period to the diagnosis. And part of my role really is to continue to foster for my clients a really proactive stance, because you have to continue to, there is that watchful waiting period. And at the same time, for some clients, there may be specific treatment that is recommended. And there may also be a need to really talk with them about that and to facilitate them to continue through that process. With Ken and Jane specifically, there was, I would say, mild pain, maybe moderate pain, specifically with erection. And I think that there was continues to be anxiety that's lessened over time, but anxiety related to penetrative sex, as was referenced. And I think at the very beginning, and even since then, there's been a lot of avoidance related to penetrative sex. As part of my assessment as well, there was not necessarily a history of Peyronie's disease with Ken's family. However, that as well, my experience is that that is oftentimes a difficult thing to assess, given how families often function around talking about sex, talking about health. There's a lot that is not discussed. And so therefore with Ken, there was no history of Peyronie's. But one of the things that also I think comes up, not just it's a part of the assessment, but comes up as part of sort of the process of working with clients around Peyronie's diagnosis or any sort of male sexual dysfunction, is this idea of what is their understanding of how they define sex? Are they, oftentimes there's a very narrow definition specific to a performance, to penetrative sex, to chasing orgasm, for lack of a better expression. And part of what I need to, and what clinicians need to do, is really to not just assess, but really slow down, normalize the anxiety and slow down the clients and create space for a discussion about that, and really understand how they're making meaning of this diagnosis and how they're making meaning of their sex life in general. And I often think that as you think about that idea of depression that Dr. Alba referenced, I respect, everyone knows this, when you have that diagnosis, you have a lot of, if you look at mental status exam, you have a lot of negative thought content, thought process that oftentimes can be something that specifically is kicked up as well in sort of the acuteness of the diagnosis. It's scary. And so what I go to is there can be not a lot of, but there can definitely be associated with anxiety and possible mood and depression issues, this catastrophic kind of thinking that you have to sort of create space for and sort of, and then attend to. I think we can switch now. Thank you. I think that you referenced a number of assessment devices that are used, on the medical provider side. I think that with regard to clients, specifically in my sex therapy practice, certainly mood disorder assessments. There are some erectile functioning assessments that I may use. In this case with Ken has no other presenting diagnosis of sexual dysfunction. And so there's some strengths to this presentation. But if I were working with a male client who might have associated ED, I may be sort of giving additional assessments to sort of both get a baseline score for that and monitor it over time. Typically when I'm using assessments, I get that baseline as part of probably session anywhere from session 1 to 3. And then every 3 sessions after that, I'm monitoring the symptoms as we move forward with treatment goals and hopefully achieving those. This is a relational case. I'm also a marriage and family therapist, so I'm always thinking relationally. If Ken were presenting as an individual client, what I would be adding in here is what is the client's relational history, if any? What is their dating history? How has this led to avoidance of dating, avoidance of sex? With the relational history, I want to understand this was a relatively new diagnosis for the couple. I still want to understand the overall quality of their sexual experience as from the onset of dating through their current length of their relationship, because then you get into specifically how it is that there can be a loss associated with, albeit perhaps depending upon the case, the severity of the case, the loss can be somewhat temporary. For example, in this case, Ken's erectile curvature was less than 30%, was not experiencing any erectile dysfunction, is able to have penetrative sex. However, getting to that place still required a good amount of psychoeducation, a good amount of sort of conflict resolution, as we'll talk about, as well as anxiety management. If we can go to the next slide, I want to thank you so much. So, with this couple, they had intact sexual functioning. They were reporting at onset that they were having sex twice a month. The client was still masturbating weekly. The frequency of sex specifically had decreased over time. That was actually a presenting issue that I would argue was more of a relational issue than specifically a Peyronie's issue. The Peyronie's complicated it. But part of the challenge with this particular case is that Jane, if you sort of were to ask Jane how frequently she would like to have sex, she would have reported roughly 2 to 3 days a week. So the idea is she had a much higher frequency of desire for sex than Ken did. Ken, it probably was once a week initially, and ultimately sort of as a result of the Peyronie's, his desire for sex lessened in the short term. As I said, he didn't necessarily have a diagnosis of ED, but there was a lot of anticipatory anxiety, and how that sort of plays out is that he's able to get an erection, and the anxiety, the anticipatory pain would lead him to lose the erection slightly. And then they might stop sex. That was one of the things we worked on, stopping and then restarting. One of the things that I went through with him, I go with any male client frequently around sexual issues like this, is I want them to be practicing getting an erection and letting it go, noticing how it is that they can control on some level, if it's within their health status, the ability to get and lose and get an erection again. But nonetheless, for Ken, he had a lot of anxiety that led him to have a little bit of mild sort of deflation in erection. And so, as I said, to address that, one of the things I began to do is have him start sort of tracking some of the thoughts he had. Generally, what you're doing is you want a client to do it maybe 2 days a week, 3 days a week. You're trying to, in general, say, okay, in the morning, afternoon, evening, I want you to just think about, as you think about the diagnosis of Peyronie's, as you think about the idea of having penetrative sex, what thoughts go through your head. So you want to begin to track the thoughts, and then you want to begin to help the client to develop alternative ways of thinking within the session. You want the partner there as well, because when I go to, your point, Dr. Alba, earlier about this idea of wanting the partner to be in the medical encounter, what I go to with the partner here is the partner, like my client, both of them, they have no idea what Peyronie's is. They have no idea what this means for their sexual relationship. And so to me, sort of Jane being able to also understand that Ken is really at times struggling with some pretty negative thinking about the impact of the Peyronie's diagnosis on his maleness, his sense of identity, his sense of sexuality, his attractiveness. All of those sort of domains are very much connected to penile functioning in a certain way. So, and with regard to, his medical treatment, this was a watch and wait kind of situation. He was under the care of his urologist. He was prescribed both, was referred to me for psychotherapy, also just prescribed NSAIDs as needed. And specifically, as I said, with regard to the treatment, a lot of psychoeducation around Peyronie's. From my perspective, one of the most important things that I generally will talk to clients that the research supports that, sort of for a very small number of clients, to what Dr. Alba said, that there can be sort of a reversal of symptomatology, but for the majority of patients, it is a progressive disease. And so you have to approach treatment in a very proactive manner. So what created a lot of conflict for Ken and Jane is that Ken wanted to avoid. He didn't want to deal with it, as totally very normal, totally relatable, part of the sort of coming to accept the diagnosis, sort of a contemplative kind of stage of change. For Jane, specifically what I go to is this is an early 30s client. So generally premarital heterosexual couples, typically they're early 30s. They're oftentimes feeling a lot of anxiety around getting engaged, getting married, having children, notably having children before the age of 35. That pressure comes notably from cisgender women. And that is due to the fact that my experience is at 35, it's considered, I believe, an elderly pregnancy. I forget the language, but that is a huge sort of, for lack of a better word, stigma, I think, that leads to create a lot of pressure. And so in this case, we have the Peyronie's diagnosis, we have the pressure of where are they at in their relationship, and Ken wants to avoid, and Jane is like, what are you doing here? Why aren't you sort of, and to the point earlier, not really, especially if they're not part of the health encounters, understanding that the watchful waiting period is oftentimes, a part of the treatment. And at the same time, Kevin was given some exercises to consider. He was referred to me, but there was still a lot of anxiety around that. Another part of the psychoeducation has been around, to the earlier point of Dr. Alba, penetrative sexual positions. So what you want to assess is, and what we did assess was, what are the couple's sexual turn-ons? What are they doing sexually, whether it be oral sex, different types of penetrative sex, and then you're trying to have them assess concurrently, which do they enjoy the most and which creates the most anxiety. And that's a bit of a relational exercise. And as you can imagine, when you're like, for example, with Ken, but also with a typical Peyronie's patient, penetrative sex is high anxiety. And that's particularly true in situations where the male partner is on the bottom, because it creates both the physical pressure, but it's sort of emotional high stakes regarding, will this hurt? Will getting an erection hurt? Will I injure myself? Especially as they've read up on Peyronie's, they understand that trauma can be a part of, sort of the history of the diagnosis. But having to talk with both clients around how can we find and expand their definition of sexual pleasure. And as I said, sort of with any case like this, I'm in pretty regular contact with the medical professionals. What I go to is, my job is to continue to track the symptoms. If the client were to be sort of prescribed any type of medical treatment, if there are any side effects related to that, or any type of, sort of client report around that, I want to make sure that I advocate that the client goes back to their medical provider, but also that I'm in touch with them and letting the provider know I'm referring the client back to you around that. Because oftentimes, as probably many of you know, it's like the providers will talk, but the patient won't necessarily always follow through. And so you have to be a bit of a mind reader. And so, one of the things I just think about here with regard to this case, and I welcome Dr. Abba, your thoughts too here, is that, sort of a combined treatment approach certainly is sort of a more efficacious approach. Generally, I enjoy working with clients around these issues, because I think that this case exemplifies, looks like the slide went back. This case exemplifies the fact that this is not just a sex therapy or sexual issue case. It's also a relational case. These types of diagnoses absolutely impact the people in relationship. For example, with regard to Jane, it wasn't just an issue of disparate frequency that was sort of part of the context of the conflict. But in addition to that, you know, sort of, if you think about a concept which you may be aware of called like love styles, it's not necessarily a research informed concept, but it's a concept that's out in the ether and that clients talk about. And so Jane would talk about how sex, physical affection, physical closeness, these are very important to her. And specifically the Peyronie's and Ken's anxiety and the avoidance of sex, it led him to pull back. That created a lot of anxiety and conflict for Jane, because Jane, I think, was feeling emotionally and physically rejected. Didn't mean that they were still together, but this was one of the things that, and I didn't put it in the slide, but one of the things that I generally try to talk with clients about is that this is a relational diagnosis. It's sort of Ken's diagnosis, but it's a health diagnosis that absolutely has relational impacts, like any other sexual dysfunction diagnosis. And so that's really part of that psychoeducational piece. So could we go to the next one if possible? I just want to make sure. You know, sort of what I go to with this case is that there are a lot of strengths to this presenting issue, notably the fact that there was intact sexual functioning, that there was not, you know, an erectile dysfunction diagnosis. And I think that that's, I have had other cases where it's more challenging insofar as sort of being able to achieve, you know, a patient, you know, self-reported satisfactory sexual experience or relationship. But sort of, again, sort of, I always try to assess for strengths with any client I'm working with. I also think that in general, this client was not experiencing significant depression to the earlier slide. There was anxiety, but they are relatively functional in their day-to-day lives. And as I think I try to sort of really reiterate, notably with this client, that there's absolutely an adjustment period. And that can be very frustrating to any client, both Ken and Jane, but it's sort of more of a consistent kind of message and normalizing that, but also reinforcing that that's the vitality of following through on whatever treatment is sort of prescribed by the healthcare provider. So I think that that's the end of my slides, if I'm remembering.
It is. Well, we'll go to the summary in a minute and questions, but there's so much good stuff in here, Dr. Jordell. Let's go back and pull some things apart for them even further and talk a little bit about some of that. I'm going to go backwards a little bit, but I think so I think I like what you brought up about, especially when you come down to the bottom of your slide and you talked about the beliefs and the scripts. You know, we all have our sexual scripts of how we approach things and everything. And this puts a real monkey wrench in their script, right? It's difficult. So in terms of scripts, we like to kind of understand how does sex unfold for you? What is the script that you guys use and stuff? Could you speak just a little bit more about the scripts and how that can be impacted by Peyronie's?
Absolutely. Let me give you a good example. Wasn't pertinent to this case, but what's interesting is that sort of for men, notably men in their mid to late 20s, I think that I see this anecdotally with my male clients of color. Sometimes there can be a belief, for example, that their partner, their cisgendered female partner, should be turned on enough by them that they do not need to use lubricant with their partners. And there can be, for lack of a better word, a turnoff with the idea of using lubricant. Now, to me, when I think about a Peyronie's diagnosis, anything that supports easier penetrative sex is suggested, you know. And so to me, like, for example, certainly part of my assessment with Ken and Jane was, are you using lubrication? Understanding what lubrication they're using, assessing whether or not they're experiencing any type of, you know, sort of allergic reaction. That might be something I refer to a medical provider. But specifically, in that case, you know, sort of a script that somehow I have to be, as a male, so sexually sort of strong that she's just going to lubricate because of my prowess. That's to me an example of sort of a script that I may have to assess, examine, and then begin to both unpack and challenge a little bit, notably as it relates to the diagnosis and the treatment.
Yeah, and so some of our work comes in, right, with trying to help them manage. Now, how do we incorporate whatever into your love play that's changed? You know, now maybe positions are going to change. Now maybe you're going to need to use a lubricant. And how can we think about incorporating that into your love play so it feels comfortable and good for both of you? And so I think, and the same thing with our ED treatments and stuff, it's like, how do we incorporate this into what you're doing together so you can be successful? Because they have certain ways they've always dealt with each other. I like a lot later how you talk about expanding their thinking about what sex is, which we have to do all the time with our patients with sexual dysfunction, to kind of help them see, because a lot of our patients are programmed to believe, especially that, well, your final result is intercourse. You know, that's always where we're headed. That's home base, right? I mean, things like that, right? These are the things that we're dealing with and trying to unpack and figure out how we're going to repack for them in their love play. So I thought that was really good when you talked a little bit about that as well. So I think pulling it apart. Go ahead.
I was going to say, I'm thinking too, like, think about a presentation, and I've had this periodically where it may be more of, you're working with a you know, 60 or 70-year-old male client who had, you know, sort of either a traumatic injury or maybe had you know, post-cancer kind of sort of onset of the disease. When I work with clients, when you work with clients who are older, and I'm not too far from that, the idea is that, think about our sexual beliefs. Oftentimes we may have been raised with this idea that sex was just natural, or we didn't talk about it. And so there can even be sometimes some sexual ignorance that you or I have to, that can underlie some of our expectations around sex. And so to me, that's more oftentimes age related, almost a cohort effect. But to me, that's an example of a script where I need to, you know, sort of, it feels like both a tremendous loss to get the diagnosis, and then it's sort of like it doesn't compute. It's like, my body's not supposed to work this way. I'm supposed to just be able to get hard and have intercourse. And so, you know, sort of those are some of the things that can come up depending upon the certain characteristics of the client coming in.
Excellent. And then, you know, when you talked about the anxiety, it's funny with this case and with many of our cases in terms of the erection may start out okay. And then as the anxiety starts to creep in with the positioning and the possible pain with this or whatever, that's when they start losing the erections. And also because anxiety is adrenaline, and adrenaline's part of fight or flight, and it's not going to help with the erections. It's going to make blood move to other parts of your body. So I think, you know, I know in my practice too, we do a lot of work about trying to reduce some of that anxiety. And then how do you deal with it as it arises, redirecting your mind back to sex and away from the anxious thoughts and things like that. Do you find that as well with your practice, that you're doing some of that work with patients?
Absolutely. Certainly with this client, but I think that, you know, as I think we all know, certainly in the US in the last few years, there's a lot of existential anxiety out there, you know, sort of, but I think certainly with this client and with many of my clients, I'm frequently having to assess not just anxiety, but I think that I'm trying to get a picture of whether or not this is situational or this is likely hereditary, if this is sort of when the onset was, and if it was, for example, with Ken, he did not have a history, does not have a history of sort of anxiety that arguably impacted his functioning. I think that this was very much situational and applied to the presenting issue. So you want to understand sort of through your assessment whether or not it is situational or it's larger, if this is someone who may have a history of anxiety and it's impacting a number of different areas of their life. However, ultimately coming back to treatment, you absolutely want to be addressing that in, within the context of the treatment, which I did. And usually for me, it's through CBT because it's sort of an evidence-based approach to dealing with anxiety.
Excellent. And so he's referring to cognitive behavioral therapy.
Thank you.
Our group is not as in tune to some of that necessarily. They may or may not be, but just to make sure. Excellent. That's great. And then I was trying to, I do think so often we do see clients with disparity between frequency of it. And of course, when we have an onset of medical issues with sexual dysfunction, avoiding sex. And I think that's can be a big problem as well.
May I add to that?
Please.
One of the things that I think about with regard to that, like think about Ken and Jane. On one level, part of what I shared is, Jane sort of looking for sex, physical touch, affection. I referenced a number of things. Now, what I go to is when you think about trying to, with any client, expand the notion, any Peyronie's presenting client, expanding the notion of sex, not just penetrative sex, and trying to continue to reduce anxiety and also sort of reinforce the male client's ability to control his erection if he has erectile functioning. But even if he has trouble with that, if it's treated, how can he continue to reconnect with his ability to do that? What I go to here is like with Jane isn't just looking for penetrative sex. She is looking for foreplay, physical touch, closeness.
Mm-hmm.
She isn't even looking always even for fully consummated penetrative sex. She's looking for initiation. And so if I take Ken pre the Peyronie's sort of diagnosis, and then I also think about, okay, what was your initial sex like? What's the frequency like before this? Then what I also want to get into as well is, how he approaches foreplay. What is his understanding of physical touch? How does he engage in affection in a physical way? Because one of the things that I think is pretty typical of Ken is that sort of most of his sexual drive is focused on penetrative sex.
Mm.
And sort of while there are certainly moments of physical closeness, there's room for growth in being able to expand one's understanding of, being embodied and being able to enjoy physical touch, both initiating and receiving it. And one of the things that I have done a little bit with this client, and I often would specifically, I usually will prescribe these types of exercises. They're called sensate focus.
Mm-hmm. Yeah.
They're couple-based sort of exercises that are progressive, and they start with clothed touch. They move into sort of partially closed touch. They move sort of, think about it, from the outside of your body down to more towards genital touch. But it's not generally it's not generally used for this type of diagnosis. But I also think the reason why I use it frequently with clients is because I'm trying to get them to begin to reconnect with their body, to practice physical touch without the aim of sex. And I think that Ken, that's an example to me of Ken needed to sort of learn that, and Jane needs to see that and experience that so she can manage her own frustration, her own anxiety with not being able to have as much penetrative sex as she wants. Certainly not right now.
Excellent. And I think, yeah, sensei focus makes perfect sense with that particular circumstance to kind of look back and relearn some of that stuff. And I find too, like, I think it's so interesting that that also there's issues of affection and often that's connectedness and intimacy, right? It's they don't feel connected on a profound level, and all of us are hardwired for that. So that's something else that would be obviously, I'm sure, was pretty important to address with them, is that connection and that intimacy, communication on all levels.
Well, what I go to is it's chicken and egg. Is the Peyronie's the presenting issue, or is there a sexual functioning or quality of sexual functioning issue? And that's part of the reason why I ended up going into this type of work, because I think that when I'm working with clients in relationship, sexual functioning is a part of, sort of that overall picture of health. But I also, what I go to is that the Peyronie's was the acute diagnosis, but I think that what it does is oftentimes this type of diagnosis exposes underlying strengths and challenges within the presenting client with regard to their sexual relationship.
I agree with you too. That's one of my favorite things about practice. It's one thing I like to help people with treatments, but I love to increase affection, intimacy, and love in their lives. And I think that is a really important thing because we all could use more of it. And I think it's great. I did see a question, a comment in here and then a question, which I thought was excellent. There's a lot of great studies out there. And Cynthia specifically talks about the Swedish study conducted, very large study. And the study showed that men with Peyronie's disease were at an elevated risk of psychiatric diagnosis, including anxiety, depression, and self-injurious behaviors. And that was from 2021. So her question is, should we be screening our mental health disorders in men with PD? And I think you had said earlier that you do believe that's important. And I think there's a couple tools that we could use as well. And I'm anxious to hear what you think about that. And if so, what screening questionnaires outside the PHQ-9 should we use?
An interesting question. I think that what I go to is, I think as a matter of course, we should be screening, obviously, for potential mental health diagnosis, psychiatric diagnosis. But I also think that what I wonder about is the reliability of sort of those with regard to the timing. I think that, and I respect that Dr. Alba and others here probably know this, certainly know this more than I do. But when I think of in my own practice as a mental health provider, that first session, while Ken came in clearly with that diagnosis, there's no way that I'm going to learn everything I need to know or hear sort of the total truth in that first session. It's going to take time for the client to trust me and to be able to sort of, I have to, when I'm doing a sexual assessment, I'm having to really check in. Would it be okay if I ask you some questions about this? Checking in afterwards. How did it feel to answer some of these questions? Really reinforcing the client's power and agency. It's like, if there's a question you'd like to not answer right now, just let me know. And so to me, what I think about is if you have a male client coming into sort of a specialist for a potential sexual health disorder, I think that their level of sort of discomfort, for lack of a better word, is probably pretty high. And so what it makes me wonder is whether or not they'll underreport, or if they will sort of just come across even more anxious than they already are. So I do think that it's good as a matter of course to reinforce that sort of mental health is part of overall health. But I also think that what I go back to is just in general, that collaboration, referring them for mental behavioral health and people like myself, so that we can work with you to sort of continue to assess for that. Because I think that when I think about especially this idea of timing, what if the symptomatology comes up after the diagnosis? They're more in, sort of survival mode when they're going through the process of figuring out what's going on, and the symptomatology can build,
Mm-hmm. I think too, like sometimes, because we're definitely pressed for time, I always say I spend an hour with each new patient and bill for that, but but it never seems like enough. And so I think sometimes even what I try to do more towards the end of the discussion with my patients with sexual dysfunction period is I try to ask them a little bit about, are you experiencing depression, anxiety, distress, or anything around these issues? And I say, because some patients do, and normalize it for them, and then say, because I have a list of providers and people that can help with that. So I think it is very, very important to do all those things. And I really appreciate all of your insights and comments. This is excellent. So thank you so much. Let me go over here and see if there was anything else I thought we'd tease apart. No, I think that information's very good. In summary, and then I didn't see any other questions, but we'll ask one more time about questions and finish up, because I know all of you have had a busy day like I have at work, and a busy evening as well, and want to get to your other concerns and family, or even your time to yourself.
I actually, Dr. Alba, sorry, I actually see two now. I
Okay.
see, yeah.
Okay,
Would you like me to go?
we'll grab those in just one second. For
Okay.
summary, we just want to say that Peyronie's disease, it's a common medical issue. We see it a lot in the urology practice, that Peyronie's disease can have serious implications for patients' sexual health and also for a patient's psychological mental health. Multiple studies have indicated that psychological distress can occur in the majority of men, and so we need to be thinking about that. And so just like we were talking about, we want to include partners in our when we're working with patients, if they have a partner and partners are willing to include them in the visits, and then to provide information, resources, and provision for mental health resources, including a referral to trained sex therapists or counselors. Let's get to those questions. So that's pretty much what we had to say about it, and we'd love to hear more from you. So go ahead, Christian, with what you heard from the chat.
One of the ones I saw, if I was looking, was about, gotta love it, over-the-counter products. I believe it sort of disappeared from the chat, but nonetheless, I believe it was sort of like over-the-counter products that assist, for example, with penile stretching. I think that as a, sort of, I'm curious your position, Dr. Alba. For me, whenever I sort of, whenever I hear a client refer that or talk about that, I'll usually reply, I have to do some research on it. So I like to do a little check it out. I'll connect with my own supervisor group and the listservs of the professional organizations I belong to. And then usually where I'll land is, sort of, I'll probably consult with their medical provider and then send them back to them. But as a matter of course, if you look at the research which was put out there, that ultimately I don't necessarily recommend them, although I don't outright say that because I really I don't feel it's my position to do so.
I think it's a little bit of a tricky thing, because you want to make sure we don't cause further trauma or problems. But I know Landon Troust specifically created a stretching device that we do have in our clinic and we use sometimes. There's other ones too, but some of the problem with especially the stretching devices was, how does somebody wear that for the hours a day that it takes for some of those devices to be efficacious? But if you look at the specific device from him, you'll see that the timing is a lot better, and he has good research to show that it might be beneficial or helpful. So I usually look at the evidence, I see what is out there and what might be helpful, and then I tell them the good, bad, and ugly of it with all the treatments, including some of these medical devices and stretching devices. I know in my clinic, it's very patient-centered. What is it? I'm going to tell you the good, bad, and ugly so you can make your own informed decision about how you want to move forward. I want to give you everything you need to empower you to make your own decisions. And I don't tell them what they should or shouldn't do necessarily. I try to just guide them through the pros and cons and help them make their own choice. And so that's what I do with those devices. And we do use them sometimes, even the vacuum pump. Sometimes there's very limited studies that show it may be helpful, but sometimes the patients want to try things. I always tell them it's critical that you're very gentle and careful when doing this, because we don't want to cause more trauma. And I do use sometimes some of the stretching devices as well as the vacuum pump for stretching. If they use it very carefully, I tell them, you know, we don't have great evidence to say it will or won't help you, but if you want to and you're willing to, I can work with you on that. So that's what I would say my answer to that question would be. I do see the two questions. They were in the Q&A section. And then you saw the next one. And I think Zoom and COVID has helped us a lot with people who are in underserved area, because we can see patients now remotely better than we ever could before. Because like we couldn't do an initial visit ourselves even. You couldn't bill for that remotely, but now patients can be seen remotely. What would you say to that question, Dr. Jordell?
Absolutely. I think that first of all, you want to be aware of professional organizations that support best practice around of mental health practitioners working with clients around sexual issues. ASEC, the American Association of Sex Educators, Counselors, and Therapists, is one such organization. So you want to begin to look at if there's anyone in your state. Then if there's no one in your state, then you're looking at, is there anyone in an adjacent state? Frequently, what we're seeing now is for counseling as a profession, there's more and more compacts that are allowing across state sort of telehealth services. To your point, Dr. Alba, I think that in addition to that, there's practitioners out there who are also licensed in multiple states. And so, but like, for example, here in Pennsylvania, and I'm also licensed in Jersey, if someone is in an area where there's fewer providers, I'm able to work with them via telehealth. And I have, because they're looking for specialized care and they're not able to find it in their sort of area. And so I would start with looking at sort of those listserv to see if anyone's in their area, in their state, and then begin to sort of work down from there.
Yeah, similar. I give people my list of providers and then I give them the ASEC website, because when you go on the ASEC website, it's going to guide you to each state and give you all the providers in that state. So thank you for bringing that up. That's a great point. And so because too, I mean, people are inundated after COVID and it's difficult to get patients in for a lot of these therapies right now. So sometimes I'll give them those lists and they'll find that really helpful, and using the resource of ASEC, because it has a find a provider directory kind of thing for patients as well. So really good point. I think we have answered the questions. I didn't see anything else pop up, and we've covered a lot of information over this hour. I cannot thank you enough, Dr. Jordell, for the excellent insights and thoughts that you had from the paradigm of the psychological distress to help us understand this better this evening. It was excellent. Thank you so much for your sharing your expertise.
It was such a pleasure. I enjoyed being with you and collaborating with you.
I don't have anything else. So if there's nothing else from anyone else, I believe we will wrap up, and thank you all for spending your evening with us this evening. I hope it was helpful and informative, and hopefully we'll see you at future SMSNA events. Thank you so much.
Thank you. Bye-bye.
Bye-bye.